I will talk today about instant restenosis. I will focus in the first part about the concepts, types, and classification and outcomes of instant restenosis. And in the second part, I will focus on the invasive management of instant restenosis. First, what are the two big mechanisms of instant restenosis? There is one, the mechanical mechanism, which is a stent underexpansion, and the second mechanism is instant tissue growth. And there are two subtypes of those. You have neointimal hyperplasia and neoatherosclerosis. Now, we lump those two together because they are managed similarly from an interventional standpoint. However, they have different mechanism and pathophysiology, and I will highlight that in a little bit. Regarding stent underexpansion, it's very important in today's era, especially in our treatment of heavily calcified disease. When the stent is underexpanded, milder degree of neointimal hyperplasia and tissue growth will manifest as significant stenosis. Underexpansion is a common factor in DES restenosis, where neointimal hyperplasia is milder than what you see with bare metal stent, and therefore stent underexpansion becomes a major factor in 40% of DES restenosis, half of which have codominant effects of underexpansion and neointimal hyperplasia. So about 20-25% pure underexpansion and 20-25% are a mixture of underexpansion and tissue growth, and 60% of DES restenosis are predominantly tissue growth. Underexpansion is even more likely and more important if you have restenosis of two layers of DES. So what is a stent underexpansion? The standard definition is it's an expansion that is less than 90% of the distal reference lumen. So this is how you size the stent and how you define underexpansion. You look at your distal reference lumen and proximal reference lumen, which are area with the least plaque burden, less than 50, ideally less than 40% plaque intima burden. And you size the stent expansion to that reference lumen. The stent should be over 90% the distal reference, or over 80 to 90% the average proximal plus reference lumen areas. So underexpansion is less than those numbers. Also, an easy way of defining stent underexpansion is achieving the nominal stent size. If you have a 3 millimeter stent, it should at least expand to 3 millimeter lumen, which corresponds to 7.1 millimeter square area. Now, some people define stent expansion in terms of the external elastic membrane. Be careful, do not define stent expansion in terms of the lesion external elastic membrane. If you use external elastic membrane, you may use the reference external elastic membrane, the reference area external elastic membrane, and what you do, you measure that and you take 0.5 millimeter from it. You reduce it by 0.5 millimeter. But do not use the lesion external elastic membrane. This reference external elastic membrane has been used in ISIDE in Illumin trial. Distal reference external elastic membrane minus 0.5 millimeter. In ultimate trial, they allowed an option of 80% distal reference external elastic membrane. But my preference is use the distal reference lumen, proximal and distal reference lumens. Now, I will move to the mechanism and explanation of the instant tissue growth. What is neointimal hyperplasia? Neointimal hyperplasia is a smooth muscle cell migration to the surface of the strut, followed by cellular proliferation and production of extracellular matrix. So the key word here, smooth muscle cell. That's what some people don't know. They think neointimal hyperplasia is endothelium. Yes, but it's formed from smooth muscle cell. That's the neoendothelium. It's a smooth muscle cell. That's what the drugs and the drug-eluting stents focus on, inhibiting the proliferation of smooth muscle cells. Plus, you get fibrosis with it. Conversely, neoatherosclerosis, which is a mechanism that has been recognized in the last 15 years, is neoatherosclerosis that grows over the stent neointima. Okay, it's different from neointimal hyperplasia. So it is not smooth muscle cell and fibrosis. Neoatherosclerosis is atherosclerosis, the same thing you get in de novo arteries. So it's lipid-laden plaque with foamy macrophages and a fibrous cap, sometimes a thin fibrous cap that ruptures and causes thrombus formation. Sometimes you can actually have calcification, even heavy calcification in neoatherosclerosis, and I will show that. Neoatherosclerosis appears earlier and more frequently with DES. It starts at 1 year, and it's seen in some degree in 30 to 50% of DES at 1 to 2 years. In BMS, it is seen, but it's more attenuated and more delayed. Neoatherosclerosis explain late restenosis and the very late stent thrombosis in both DES or BMS. Neointimal hyperplasia form in between 1 month and 1 year. Neoatherosclerosis is a process that occurs beyond a year. So while bare metal stent in stent restenosis occurs at 3 to 6 months and peaks at 6 months after stenting, DES in stent restenosis peaks at around 8 to 12 months after stenting, but it continues to increase more steadily for several years after DES, particularly because of this accelerated neoatherosclerosis. So it's a very important process in DES beyond 1 year. Now, neoatherosclerotic restenosis mechanism is similar to native vessel atherosclerosis, and it grows in parallel to that with all the standard atherosclerotic risk factor. However, neoatherosclerosis is an accelerated atherosclerosis and is more accelerated compared to the de novo atherosclerosis. In native vessels, atherosclerosis takes years and decades to develop, whereas in the stent, neoatherosclerosis seems to occur in months to years following stent placement. And, you know, kind of this is the hazard of DES used for moderate disease, those 50%, 60% disease, even if it is a hemodynamically significant disease, because you might convert a native atherosclerosis into something that is more aggressive over the long term. So be careful. I like to stent critical disease. That's one of the reasons. So why is it a little of a more aggressive atherosclerosis than native vessels? One of the reasons is that in neointima, you have looser cellular junctions between the smooth muscle cells, which allow more lipoprotein penetration into the subendothelium. That's one theory that explains the more aggressive neoatherosclerosis growth. It's more aggressive if the underlying lesion was unstable as an MI. It's more aggressive with the old first-generation stent compared to second-generation DES, which create less vessel injury and less inflammation. I will show you some images, intravascular imaging. Intravascular imaging is key in defining the two big mechanisms of in-stent restenosis and treatment, underexpansion and in-stent tissue growth. Now, like I said, it's not very important to distinguish between neointimal hyperplasia and neoatherosclerosis in terms of management, but still, I want you to see how they look different. So this is neointimal hyperplasia by OCT. It looks like a thick, fibrous, bright tissue that's homogeneous. Conversely, neoatherosclerosis looks more like a lipid-rich plaque. Those are the dark area inside the plaque. You can see a cap. Sometimes it's a thin cap. Sometimes it's a thick cap. And sometimes you could see a thrombus inside it. By IVUS, it would be kind of the same. You will have a thick, bright, echogenic, white, homogeneous structure in neointimal hyperplasia, whereas in neoatherosclerosis, you will have dark spots of lipid-laden plaque. Those are other images by OCT. This is neointimal hyperplasia, thick, homogeneous structure. Those two are neointimal hyperplasia. This one is actually neoatherosclerosis. You have a thick fibrous cap that is bright yellow, but below it you have this lipid. Remember, by OCT, lipid is this dark, loose structure. It has loose edges and it creates shadowing behind it. It's not well demarcated. That's a classic of lipid, what you see here. All this here is lipid. Those images are important for interventional boards. So you have a cap, a fibrous cap here. Then you have a lot of lipid behind it. This is neoatherosclerosis. You cannot even see the stent struts in this patient. You can barely see it here because the lipid creates shadowing and it shadows the stent struts. You can see the stent struts here in neointimal hyperplasia without lipid. This is another neointimal hyperplasia here. Again, a lot of dense lipid with shadowing and loose borders. There is a thrombus here. There is a thrombus here. Again, lipid-laden plaque. This is another image to illustrate that. Again, this is neoatherosclerosis, a lot of lipid. Look how much here, how much shadowing and loose edges you have, dark plaque. And you can see thin cap here. And you have a plaque rupture somewhat here. So this is a plaque rupture of neoatherosclerosis. I want to show you this important image. This is a stent here, and you have heavy calcium inside it. It's not very common, but it can happen with very late neoatherosclerosis. You can start seeing calcium, even heavy calcium. Now, how is calcium by OCT? I will remind you, it's a little different than IVUS. It is a dark structure on OCT, kind of like lipid, but the difference is that it's well demarcated and it doesn't create shadowing behind it. So you still see the stent. Unlike by IVUS, where you get shadowing with calcium, here you don't get shadowing. It's well demarcated and you actually see the stent behind it. It tends to be more heterogeneous. So he has calcium here and here. This is over 180-degree arc of calcium. This is by IVUS. This is the stent here. You see the stent struts. And you see inside it that echogenic white tissue growth. This is neointimal hyperplasia, and this is the lumen, the dark one. So this is the neointimal hyperplasia, and this is the stent here. Behind the stent, you can see the old intima and external elastic membrane. The important thing is what's within the stent. So here is what we look at when we do intravascular imaging. When we look at that stent area, the minimal stent area, we compare it to the distal reference and proximal reference area. You could use, like I said, the distal external elastic membrane minus 0.5 millimeters. This is how you assess the proper stent expansion. That's one. Two, you look at that in-stent tissue growth and you measure it. You measure that area of in-stent tissue growth. The area of in-stent tissue growth is that area here I have in blue divided by the full area inside the stent. If it is more than 50%, this is what we consider significant neointimal hyperplasia or significant in-stent tissue growth. Now I will move to the classification of the patterns of in-stent restenosis. This classification is from the era of bare metal stent by Dr. Mehran from the 90s. It's still very relevant in the era of DES. So there are different patterns of in-stent restenosis. The first pattern is the focal pattern, where you have a focal area of in-stent restenosis less than 10 millimeters. It could be in the middle of the stent or it could be at the edges. And here I will remind you that any stenosis within 10 millimeters of the edge of the stent is considered in-stent restenosis. It's not considered necessarily a separate atherosclerotic process. It's considered related to the stent injury. We call it in-segment restenosis, but it's fine to use in-stent restenosis. The second big type is what we call diffuse in-stent restenosis, which is longer than 10, often much longer than 10 millimeter, and it may be contained within the stent or could extend outside the stent and may even be occlusive. The importance of this classification is that it predicts the response. The focal in-stent restenosis responds well to just balloon angioplasty, even though that's not the best modern treatment of focal in-stent restenosis. We know it does respond well to it. Even in the BMS era, ballooning focal in-stent restenosis was associated with only close to 20% recurrence of restenosis. Conversely, the diffuse one have very poor outcome with just ballooning the restenosis, and with pure balloon angioplasty, the restenosis rate is upward of 50% and even up to 80% if you have occlusive instant restenosis. Now, in the BMS era, in Mehran's paper, most restenosis were diffuse. So BMS not only caused more restenosis, it also caused more extensive restenosis. The beauty of the DES is that not only they inhibit restenosis, they cause less aggressive restenosis. It tends to be more focal. 60+% of DES restenosis are focal. The other ones, about 35-ish% are diffuse or occlusive. Now, I cannot talk about stent restenosis to fellows without trying to distinguish it from the other big process, stent thrombosis. Generally speaking, stent thrombosis and stent restenosis have different presentations and different timings. However, there is a lot of overlap, as I will show. And that's why you should always, in an MI presentation with a stent obstruction, think stent thrombosis or stent restenosis or both. Stent thrombosis is most commonly subacute, less than 30 days. And it occurs, you need to know those numbers I highlight in red. It occurs in 0.5 to 1% of stent. The traditional number is about 1% stent thrombosis in the first month. However, late stent thrombosis, which is 1 month to 1 year, or very late stent thrombosis, which is over 1 year, and you need to know those definitions, those are seen these days, and their timing overlaps with the timing of instant neointimal hyperplasia, which is that 30 days to 1 year, or instant neoatherosclerosis, which is more than 1 year. Okay, and a lot of time you have a combination of instant tissue growth plus stent thrombosis in those late presentations. In fact, what's the frequency of very late stent thrombosis beyond 1 year? To my surprise, in the most important trial, in DAPT trial, the risk of stent thrombosis beyond 1 year with DES and even BMS was about 0.3 to 0.9% per year beyond 1 year. The 0.3% was if you do use dual antiplatelet therapy, 0.9% if you use single antiplatelet therapy. But that risk also varies with the initial presentation. If your initial presentation was MI and you have underlying unstable plaque, you're more likely to have long-term risk of stent thrombosis and very late stent thrombosis. If your DAPT score is 2 or more, you're also erring more on the higher end. That's why those patients likely benefit from a longer duration of DAPT beyond 1 year. But stent thrombosis continues to occur. You have a chronic attrition rate of about 0.3 to 0.9% per year. Late and especially very late stent thrombosis mainly occur on top of instant tissue growth. For example, rupture plaque of neoatherosclerosis beyond 1 year. They may occur also on top of a little bit of stent underexpansion. That's why stent thrombosis and stent restenosis can have a lot of overlap. And IVUS will help you figure that out. You need to know those numbers. I will give you the numbers, kind of to sum up all those mechanisms. Okay, well, what's the frequency of all those mechanisms I just described? This is an important slide of when you talk to the patient. What's the long-term risk of events? So when you put a de novo DES in a lesion, you have a 10%, around approximately 7 to 10% risk of restenosis at 1 year, which will be mainly neointimal hyperplasia. And you have about 1% risk of stent thrombosis at 1 year. So those are the numbers at 1 year. At more than 1 year, you continue to have, like I said, a risk of stent thrombosis of anywhere between 0.2% in company stent registries to 0.9% in DAPT per year. So significant risk per year. Then you have a 1 to 2% per year risk of instant restenosis, like obstructive neoatherosclerosis. So 1 to 2% instant restenosis and 0.2 to 0.9% risk of stent thrombosis per year. So you can add them up at 5 years, at 10 years, what happens. So at least, and keep in mind, at least as many events, MI or revascularization, arise outside the stented area, whether inside the same vessel or outside it. So at least 50% or total event in the first year or beyond it are plaque progression outside the stented area. So that's another downside of stents. Not only that long attrition rate of instant restenosis and slow risk of instant thrombosis, it's also that eventually most of your event will arise from plaques around it. A stent is a focal treatment, unlike CABG, which is a treatment of a more diffuse disease. So I want to give that slide, which shows the presentations of instant restenosis, stent thrombosis, and how they overlap. So stent thrombosis is clinically more dramatic, usually, than stent restenosis, and often presents as a STEMI or large non-STEMI. However, instant restenosis overlaps with that presentation for a couple of reasons. One, instant restenosis, even without any thrombus, can be severe enough, and in 10 to 20% of the cases, up to 30% in some registries, it can present as non-STEMI. Two, instant restenosis and stent thrombosis, as I explained, may coexist. For example, you have a thrombus on top of tissue growth or thrombus on top of underexpansion. That's why in any MI presentation, it's very important to rule out a combined mechanism of instant restenosis plus stent thrombosis. That will change your management, as I will explain in a little bit. Another idea I want you to know from that slide, the various clinical presentation of instant restenosis. So yes, it can present as MI in 10 to 30% of the time. Most often it presents as angina, progressive angina, exertional angina, or rapidly progressive angina. But I want to focus on that idea, which is an important board question. Up to 40% of instant restenosis are asymptomatic, especially instant restenosis in the range of 50 to 70, 80%. And this is a board question in terms of treatment. And this is the first idea of treatment. Avoid treating asymptomatic ISR. ISR is asymptomatic up to 40, 50% of the time, in which case the prognosis is very good. Routine stress testing or routine angiographic follow-up after stenting to try to find that asymptomatic instant restenosis and to try to do routine PCI of asymptomatic instant restenosis has not improved outcomes compared to angina-driven PCI. This is based on registry data and, most importantly, the post-PCI trial, Korean trial published in the New England Journal of Medicine this year, 2022. And in many registry data, compared to post-PCI angiography that is driven by symptoms, doing routine post-PCI angiography at 6 or 12 months increases the detection of asymptomatic restenosis and increases repeat PCI, but does not improve clinical outcomes such as death MI or long-term TVR. Again, that shows you that asymptomatic instant restenosis should not be treated at the asymptomatic stage. I will move on to the other big topic of this talk, which is the invasive management of instant restenosis. So this is my algorithm. It's a simplified algorithm compared to what you may see in state-of-the-art papers. When you have instant obstruction, the first step is to do intravascular imaging and stent boost. Stent boost is a cine image that focuses on the stent and looks for stent under expansion. So you do those two. And you define the two major mechanisms. Is it stent under expansion or tissue growth? You also define whether they coexist. If it is a stent under expansion, the first step is to do high pressure, non-compliant balloon dilatation at 22 to 25 atmosphere. Assuming this doesn't work, those are the two big treatments I want you to know for stent under expansion: laser atherectomy and lithotripsy balloon. Those will try to break the calcium and or the fibrosis behind the stent, the plaque behind the stent. Lithotripsy will break the calcium, laser will break the calcium and or the fibrosis behind the stent. And if you want to remember two procedures in stent underexpansion is those two, laser atherectomy and or lithotripsy balloon. We often start with lithotripsy balloon. It's easier to use and it's more widely available. Then if this doesn't work, laser atherectomy is a proper option. Rotational atherectomy may be used in stent underexpansion. The point would be to actually shave the stent and shave the plaque behind it. It's as associated with risks. So it's definitely not a favorable option, but it can be done. The second process, which is tissue growth more than 50% of the stent area, regardless of whether neointimal hyperplasia or neoatherosclerosis. There are three types of treatment, two main types. Restenting, if you have one stent layer, and that's the one that has been associated with the best outcomes, re-DES, sandwich DES, we call it. If you have one or two stent layers, you can use drug-coated balloons. Those are not available in the US, unfortunately, despite large amount of data from Europe. They are widely available in Europe. They have been available for many years. The third option is brachytherapy. This is reserved for two stent layers, especially restenosis of two stent layers. So generally speaking, for tissue growth, the two big treatments are restenting, if one stent layer, drug-coated balloon, if you have one stent layer, or two stent layer. One stent layer as an alternative to restenting, and in two stent layer as the best option, drug-coated balloon. Brachytherapy if you have recurrent restenosis in two stent layers. Okay, do not restent if you have already sandwich stent and two stent layer. Those are the only option if you have two layers of stent. And sometimes, again, you have combined mechanisms. So you need to do laser and or lithotripsy and restent, or laser and lithotripsy and drug-coated balloon. Now, keep in mind, this is the most important slide of this talk, and I combine here instant restenosis with the necessity to rule out stent thrombosis. In any MI setting with a stent obstruction, think of stent restenosis mechanism, stent underexpansion tissue growth, but also think of stent thrombosis. Why? The management is a little different. If you have a stent thrombosis with less than mild tissue growth, meaning you have stent thrombosis and the tissue growth is less than 50% of the stent area, do not restent. Just balloon plus or minus thrombectomy and try to improve stent expansion with higher pressure and maybe even with laser atherectomy, which works also well for thrombus. So that's what you need to do with stent thrombosis. Do not restent. So the only time we restent in this slide is if you have instant tissue growth inside one stent layer. That's really where you restent. In none of the other isolated scenario, you restent. Okay? And this is an image here of a patient who presented with MI. This is an IVUS image. So you can see here the stent struts. Okay? And what you can see inside the stent, you can see that you have this dense white echogenic structure that is significantly stenotic. This here, all this here. All this is neointimal hyperplasia. But you also have that big structure here. This is actually instant thrombosis. So this patient has a combined mechanism of severe instant tissue growth, more than 50% of the stent, but also instant thrombus formation. So this patient, we treated him with balloon angioplasty, but we had to put another stent because of the instant tissue growth that may have been contributing to the thrombus formation. So it's a mixture of thrombosis and significant tissue growth. Now, I want to describe some outcomes from this slide. Okay, what are the outcomes and some details of each one of those procedures? So restenting in somebody who has DES restenosis, restenting has decent outcomes. You have about 15%, close to 15% risk of recurrent restenosis at 1 to 2 years. But this number is higher if you're restenting diffuse ISR or if you're having occlusive ISR, up to 30% if you're restenting CTO ISR. With DCB, it's also good result. The number of restenosis, recurrent restenosis is a little higher with DCB, but still decent, especially that you're avoiding a second layer of stent. It's close to 20% at 1 to 2 years. If you do standalone angioplasty, like I said, the restenosis rate is around 50%. It can be good, 20 to 30%, if your restenosis is very focal. Okay, that's not a standard treatment, however, for in-stent tissue growth. Both repeat DES or DCB are option for DES restenosis. In the more aggressive DES restenosis, that is diffuse or occlusive, you probably should consider another DES placement. If you have focal in-stent restenosis, consider DCB, since it has very good outcomes, not as good as repeat DES, but quite good. And again, you avoid placing another layer. I want to remind you here one thing. In DES era, I said most in-stent restenosis, the good thing is that they are focal, and they tend to be focal around the edges, sometimes due to what we call geographic miss, meaning you balloon at the edges or you pre-ballooned at the edges and create restenosis there. And so focal ISR may be treated with DCB. This is some data comparing DES with DCB, and you can see in all of those studies, the one-year MACE favors DES over DCB, but the margin is not very large. This is a meta-analysis of all those trials. The numbers here are too good to be true. At 1 year, the restenosis rate was only in the range of teens% with both strategy, even at several years, 16% versus 12%. In reality, in the real world, the numbers are higher. They are about 10 to 15% at 1 year with sandwich DES and 18-20% with DCB. And like I mentioned, you have diffuse in-stent restenosis. The numbers are higher. You go to, even with restenting, 25% recurrent restenosis versus 10 to 15%. An important thing about that classification of diffuse versus focal is not only what's the risk of recurrent restenosis, it also predicts if you do have recurrent restenosis, what type it is. So if you have focal ISR and you restent it or DCB it, if it recurs, it will recur as usually as focal ISR. If you have diffuse ISR and you treat it, it will usually recur as diffuse and occlusive in more than 2/3 of the cases. So another idea here, if you have 2-layer DES, how do you treat those? I mentioned definitely avoid a 3rd-layer DES. That's a very important idea. There is very little data on what's the outcome of placing a 3rd-layer DES. But what we do know that doing a drug-coated balloon for 2-layer ISR is associated with decent outcome. Actually, with DCB in this study, doing DCB for 1 or 2-layer in-stent restenosis was associated with similar and favorable long-term outcomes. So 2-layer DES, DCB is the best option. Again, unfortunately not available in the US, but in Europe, that's definitely the best option. And it's around 15 to 20% TLR at 1 year, similar to 1-layer. Brachytherapy in the US, in centers where it's available, is a good alternative option for 2-layer in-stent restenosis, particularly recurrent in-stent restenosis, despite DCB for 2-layer ISR. So here you have about, when you do brachytherapy, you have about, it's similar to DCB, around maybe a little better, around 15% TLR at 1 year and 26% TLR target lesion revascularization at 2 years. And keep in mind, when you have 2-layer DES restenosis, the likelihood of underexpansion is even higher than the standard 40% I mentioned in DES restenosis. So you keep a low threshold to do lithotripsy or laser for underexpansion. And keep in mind that with 2-layer DES restenosis, think of CABG if the patient has LAD disease and he or she are good candidates. So we don't have, I couldn't find data about the long-term outcome of putting a 3rd stent, which I try to never do. However, we know that if you have a 3rd stent and you restenose that 3rd stent, doing DCB on a 3rd layer of stent is associated with very poor outcome. 50% recurrent restenosis at 1 year if you do DCB for 3-layer stent. So very poor outcome. Same with brachytherapy for 3-layer stent. It's around 50% recurrent restenosis within the next couple of years. So try to avoid 3-layer DES. Treatment on 2-layer DES, at least you can keep redoing it, and it's associated with better long-term outcomes. I have 2 additional notes. Brachytherapy is a catheter that has an isotope, strontium isotope, at its tip, and it delivers local beta radiation to suppress smooth muscle cell proliferation. Second note is regarding drug-coated balloons. Those are balloons that are coated with an anti-proliferative drug, typically paclitaxel, and they are also coated with a lipophilic matrix or excipient that delivers the drug. When they are inflated, they allow quick transfer of this drug into the vessel wall during a single balloon inflation. The drug is rapidly uptaken by the vessel wall, and a few % of the paclitaxel stays in that wall for a few weeks or even months, despite the short balloon inflation and delivery. DCBs are given a class 1 recommendation in the European guidelines for instant restenosis. So additional ideas and devices here. One, I want to describe the cutting balloon. The cutting balloon is a balloon that has 4 longitudinal blades that disrupts and soften the plaque. Those blades create micro incisions in the plaque, and based on a study using IVUS, an old study using IVUS called REDUCE-1, those blades allow more lumen gain than standard balloon with less vessel stretch and less elastic recoil. So you create a larger lumen with less vessel expansion in both calcified and non-calcified lesion. And it comes in 2 to 4 millimeter diameter and use the short length. It tends to be difficult to advance, but in my opinion, when you use those very short length, 6 to 10 millimeter, despite the higher profile, I haven't had very much difficulty to advance it. You do need to use a standard balloon before to open some channel for it, then you can advance this balloon. Now, keep in mind a very important idea. Even though you get more lumen gain with cutting balloon versus standard balloon, and you get better acute immediate result versus a standard balloon, old studies of angioplasty versus cutting balloon in de novo lesions from the 90s have shown that restenosis, that was the balloon angioplasty restenosis, was the same. So cutting balloon by itself as a standalone treatment doesn't have much value. It has value as a preparation, improving lumen gain, as a preparation to something else. If you're stenting de novo in a calcified lesion, especially mildly to moderately calcified or fibrotic lesion, it's a great tool to prepare your lesion for stent placement and getting better stent expansion. But as a standalone, it has no value. Actually, for restenosis, it doesn't have much value. There is an old trial in the BMS restenosis area of standard balloon versus cutting balloon. They had the same recurrent instant restenosis. So cutting balloon in the instant restenosis is only useful as adjunct to DCB. It allows better lumen gain and drug penetration before putting the DCB, inflating the DCB, or as a preparation to DES, not a standalone treatment. The cutting balloon has one set of data called ISR Desire 4. ISR Desire 4 trial has shown that it wasn't cutting balloon, it's what we call angiosculpt scoring balloon, but it showed that using scoring balloon in preparation before DCB improves the long-term lumen loss. So it has value in preparation. Another value of cutting balloon is that it avoids the watermelon seeding. When you inflate a balloon in a heavily fibrotic instant restenosis, the balloon tends to slip. This is what we call watermelon seeding. And it has been shown that having balloon slippage is associated with increased recurrent restenosis because it creates edge injury and therefore edge restenosis. This is what we call the geographic miss. So that's why in the guidelines, they give a class 2 for the use of cutting balloon and instant restenosis as a preparation for DS, but mainly also to avoid that watermelon seeding effect. Okay, I have also used it in cases of stent underexpansion after using more radical treatment with laser or lithotripsy to further try to soften the plaque behind the stent. There is another type of scoring balloon which uses, instead of blades, it uses 3 intertwined elliptical wires to try to modify the plaque. That's what actually was used in the ISR Desire 4 trial. In my experience, I find that I get better immediate result with cutting balloon. This is the angiosculpt balloon with the 3 wires. Another important idea here is rotational atherectomy. So you can use it in stent underexpansion, but beware of the burr getting stuck when using underexpanded stent. Definitely avoid orbital atherectomy inside the stent, underexpanded or well expanded. The orbital atherectomy orbitate at a larger eccentric diameter than rotational atherectomy and is more likely to get stuck inside the stent. So definitely avoid orbital atherectomy. I want to describe laser atherectomy. It's a very misunderstood point. Laser atherectomy only has a value in the stent restenosis field in case of stent underexpansion to try to soften the plaque, heavy fibrosis, or calcium behind the stent, or in cases of balloon uncrossable or balloon unexpandable in stent restenosis. So you have in-stent restenosis, but no balloon can cross it, or no balloon can loosen it. It's very heavily fibrotic. So you can do laser atherectomy in those 2 cases. In the second case, as a preparation for DCB or repeat DS. Laser atherectomy has no value, I will repeat, no value for isolated in-stent tissue growth. It has no value for that. It has value for this or the combination of the 2, but no value for isolated tissue growth. See, I know a lot of doctors who use it, but I see no data for it. In fact, in the angioplasty era, in the 90s, there were trials comparing balloon angioplasty versus laser for de novo lesions, and there was higher restenosis with laser versus balloon angioplasty. This is for de novo atherosclerosis. There is no reason to believe that laser will improve the outcomes for in-stent tissue growth compared to just balloon angioplasty. That's why I don't think it's a good standalone treatment. It's only a good treatment when you have those cases, not for in-stent tissue growth. And those are the trials with laser atherectomy that show worse outcomes compared to just balloon angioplasty in de novo lesions. There's another study here. There was one study called ARTIST. They used rotablation versus balloon angioplasty for bare metal stent in-stent restenosis, tissue growth, basically, not underexpansion. And actually, rotablation was worse than balloon angioplasty for tissue growth. So again, rotablation has no role for in-stent tissue growth, in-stent restenosis. It may have a role in stent underexpansion, but beware of complications in that case. So I'll describe briefly the laser. Laser is a monorail catheter that can be advanced over any 0.14-inch wire, and that's an advantage over the orbital and rotational atherectomy in cases where you cannot cross the lesion with any device. You may use your standard wire and advanced laser over it. It's 6 French guide. The most commonly used catheter is the small 0.9 millimeter catheter. And what laser is a high frequency UV light. And what it does, it creates heat and it vaporizes the plaque. The plaque evaporates, so it vaporizes the plaque, but it also creates bubble and it creates an explosion inside the plaque. So it creates vapor effect and it also creates an explosion effect, which is particularly useful in calcified disease. This is what we call the photomechanical effect. Now, laser can be used in heavy fibrosis, but also in moderate calcium, and it is very valuable for underexpanded stent. We set it up in terms of energy or fluence. We set it up usually at 80, and in terms of frequency, usually at 80, 40 to 80, but usually we use 80. And this is here the laser catheter tip. You run, when you're running laser, you should typically run saline. But if you want to create larger and more explosive bubbles, you don't run saline. You let the blood run. You create more explosive bubbles. Or in more extreme cases, you actually inject contrast. This is where you create the most explosive bubbles if you need to, but also a higher risk of perforation. It is off-label to use contrast with laser. So you may start with 0.9 millimeter, 80 and 80, frequency and fluence in saline and then in blood. Then if this doesn't succeed, you may upsize to contrast or to larger catheter, especially in larger vessel, 1.4 millimeter or 1.7 millimeters. Another idea, if you have recurrent instant restenosis of vein grafts, so 2 stent layer instant restenosis, strong consideration for fixing the native coronary if you have CTO skills, or refer them to a CTO center. Another idea, we don't talk often about it, but we do see it. It's what you call stent fracture, especially of our thin stent with poor radial strength. It is seen in 5% of all ISR, and you will be able to see it on stent boost. You may see it on intravascular imaging. Intravascular imaging, you will see an area that has no stent. So you see a stent, then all of a sudden you have an area with a stent gap. You don't see the stent struts. Those are the stent struts, okay? There is an area where you don't see stent struts anymore. So, and there are, you know, 2 big types of stent fracture. It could be partial fracture or it could be full-blown separation. How to treat this? There is no large-scale data, but the standard is if you have stent fracture with significant in-stent obstruction, you put another stent, typically a stent with higher radial strength and thicker struts, such as Megatron stent instead of Synergy stent. And I will explain that in a little bit, okay? This is another idea that comes up. Okay, well, when you put a stent inside an instant restenosis, what type of stent should you use? Should you use the same type of stent or should you use another one? No big data for that. Unfortunately, the only decent data is from a study called RIBS-3. It wasn't a randomized trial. It's a prospective, non-randomized study, mostly first-generation DES. It suggested that putting a different type of stent, what we call hetero-DES sandwich, is associated with better long-term outcome than using Homo DES sandwich. But there were a lot of pitfalls in that trial, in that study. I won't go over them. Still, it's common sense to try to use another stent, whether different stent design, platform, and or different stent drug. You know, we don't have in the US DCB, but there is a way of using off-label peripheral drug-coated balloon in rare cases. There is caveat to using that, and those are the caveat. They are 0.018-inch peripheral DCB impact or Ranger DCB. The smallest size they come in is 4 by 40 millimeters. You can use them off-label in large proximal or ostial RCA or left main. But there are a lot of caveats. That's why it's difficult to use them. They are bulky and require good supportive wire. 4 millimeters is the smallest diameter, and 40 millimeters is the smallest length. They are too long for many lesions. It's over the wire system only, not monorail. And they are advanced over at least 5 French sheath in the periphery. So you need at least 7 French guide to use them in the coronary with very good supportive wire like Iron Man. I will show you some cases, then I will stop. And I will show a couple more important ideas, including one idea about stent recoil. So this is a 53-year-old man, diabetic. He has extensive history of 3-vessel full metal jacket stenting. He was having progressive angina. It looks like he's having instant restenosis of that left circumflex stent placed 3 years ago. It's a 2-layer instant restenosis. So we did IVUS here. And you can see here by IVUS, one, he has 2 layers of stents. You can see the 2 layers, okay? 2 superimposed layers. First, assess stent expansion. Well, the stent is very well expanded. The stent, as you can see, the distance between markers is 1 millimeter. So the stent is expanded to 3 millimeters, which is a nominal stent size and which matches the distal reference lumen. So it's well expanded. However, you can see all this white thing. So there is heavy amount of tissue growth all the way to the IVUS catheter. It's white, echogenic in some places, but it's dark, echolucent in other places. You see those dark spot here, dark spot? It's most likely neoatherosclerosis 3 years later with fibrous areas and lipid-laden areas. It's very severe, way over 50%. So here, I did not use laser because, like I said, it has no value, no clear established value for instant tissue growth. Therefore, in the Europe, the best treatment for this 2-layer stent is to put DCB. In the US, what I did is I just used a standard balloon and then cutting balloon. Another option in the US would be brachytherapy, but I don't have it available at my center. So that's the only thing we used here. The hope is he will have a high risk of recurrent restenosis. Being focal, somewhat focal, the risk of recurrent restenosis, I'm hoping, is in the range of 30% at 1 year. And if this happens, maybe DCB will be available by then. I will show another case here. This is a patient with a heart transplant, and he's having stenosis inside his native right coronary artery. He has coronary allograft vasculopathy. So he doesn't have calcium, but keep in mind, those coronary allograft vasculopathy tend to have heavy fibrotic tissue. So here the operator dilated and placed a stent. Unfortunately, the lesion wasn't well prepped and the stent didn't expand well. That should not happen typically. You try to never stent if your balloon does not fully yield. You want to make sure your lesion yields before you put stent. Anyway, here a stent was placed and it was significantly underexpanded, as you can see on cine image. They tried to balloon with high pressure, 25 atmosphere, non-compliant balloon, to no avail. So eventually laser atherectomy was done. Even laser could not allow stent expansion initially. So what we had to use 1.7 millimeter laser catheter, because this is a big vessel, or we start with 0.9, then we upsize to 1.7 millimeter laser, and then we used it with contrast. And afterward, we used a cutting balloon, and we were able to make that lesion fully healed. And this is a result by IVUS of that stent. It's very well expanded to 18 plus millimeter square and about 5 millimeter stent diameter. So laser for severe instant underexpansion. Here, lithotripsy balloon would not have worked because it's not a lot of calcium. It's just a heavily fibrous lesion more than it is calcium. This is another case. This is a patient who appears to have an ostial left circumflex instant restenosis, which looks like a mixture of underexpansion and instant tissue growth. And this is how it is by IVUS. This is the stent just proximal to the circumflex in the left main. It's well expanded, around 4 millimeter in diameter. This is a stent just at the left circumflex ostium. You know, you pull back from here 1 millimeter, you end up in this. You can see the LAD here. So this is the stent of the left circumflex, and this is the LAD next to it. Okay? So you see that left circumflex stent is not well expanded. Keep in mind here, we had to dilate before we advance the intravascular imaging. And commonly in those heavily fibrotic instant restenosis or underexpanded instant restenosis, you do need to balloon before you do your vascular imaging. Anyway, so after that, this is what we see. This is an underexpanded stent. It's a 3 millimeter diameter instead of 4, and MSA 7 millimeter square instead of what should be 12.5 millimeter square. Not just that, it's maybe hard to tell here, but there are those echolucent areas inside the stent. In this case, this is probably neoatherosclerosis, okay? So it's a mixture of neoatherosclerosis and significant stent underexpansion. So we use lithotripsy balloon here. This is a heavily calcified lesion at baseline. So we use lithotripsy balloon, and we got a decent result. We increased it to 11 millimeter square, 3.1 by 4.3 millimeter ostial left circumflex expansion. And you see here the LAD next to it. This is your landmark. So we are looking at the very same point I looked at earlier, and it's much better expanded now. So here, I didn't just use lithotripsy balloon. I did put another stent for two reasons. One of them is there is some instant tissue growth. And two is what I call stent recoil, which I will explain in a minute. And this is what the angiographic result is of this instant restenosis. So lithotripsy balloon and restenting with Megatron stent. So here's the idea, an extremely important idea, I think, of stent recoil, which we're seeing more often these days, but there isn't much published about it and not much talked about it. So what is stent recoil? Stent recoil, it's like angioplasty recoil. It means that you extend your stent with a balloon and it expands to 4 millimeters. Then you deflate your balloon, the stent or part of the stent collapse to 2.5, 3 millimeters. This is what you call stent recoil. It's not like the classic stent under expansion. The classic stent under expansion, you can never yield the lesion. You can never get your balloon to expand. The stent never expands. Stent recoil is a form of under expansion, but it's a case where the balloon breaks the lesion, but then eventually the lesion collapses your balloon and the stent in this case, okay? It's the same thing that used to happen in the balloon angioplasty era, which is what you call the elastic recoil. This should not happen with a stent. That's the reason stents were invented, to prevent that recoil. However, it happens because current stent generations have thin and very thin, and sometimes ultra-thin struts. And this is part of the evolution. We use thin struts to improve deliverability, but also to create less injury. Actually, thinner stent struts create less inflammation and less neointimal hyperplasia and neoatherosclerosis. However, this comes at a price. You end up with less radial strain and a risk of stent recoil. This is particularly the case when you're stenting heavily calcified area, especially heavily calcified area at ostia. Especially the time I see it the most is aorto-ostial disease and ostial left circumflex. Ostial left circumflex is the Achilles heel of distal left main stenting. So this is where I see it the most. So how do you treat it? Well, first try to prevent it. You know those areas that will have possibly difficult stent expansion, or even when it expands, difficult stent recoil. So keep a low threshold to prep the lesion well with lithotripsy and balloon lithotripsy and atherectomy. Now, if it does happen nonetheless, how do you treat it? One study in neurointervention suggested that you can treat it using multiple high-pressure post-dilatations. So instead of doing one prolonged stenting post-dilatation, do multiple short 10-second over 20 atmosphere post-dilatation. This in vitro study showed that you may prevent or reduce stent recoil. Another way of treating it, and I have no data to support this, is when I see instant restenosis, and I think stent under expansion with a stent recoil is a big factor, I end up having to put another stent with better radial strength, such as the Megatron stent, like I did in this case. That's one of the reasons I use another stent. It's not just the tissue growth. It's the fact that I noticed that each time I expand the stent, it will tend to collapse again. So there was some stent recoil. Those are cases where I may, off-label, lack of data, I may put a stent with better radial strength. Hopefully, we will have more data on this within the next couple of years so we can get better guidance on how to treat it. This is just a slide to show you current stents. The old drug-eluting stent and bare metal stent were in the range of 140 micron in terms of strut thickness. Current generations, you need to know those numbers, by the way, if you're an interventionalist. They tend to be in the 80s micrometers, so much thinner struts and better design overall. There is one stent called Megatron stent. It tends to have a slightly thicker struts, but more importantly, it has more peaks, so it has more dense design. So it's not just thicker, slightly thicker struts, it's more number of peaks, more number of struts. And it has more links here between the columns of the stent, more links. All this creates more lesion coverage and more stent straint, okay, radial straint and longitudinal straint, compared, for example, to the Synergy stent. Another thing that this Synergy Megatron has, like the standard Synergy, is that it uses platinum, which unlike the other stent, the other ones use cobalt chromium. Platinum has more radial strength than cobalt for the same thickness. So this is Megatron compared to the other stent. It's 50% more radial strength or so, more radial and more longitudinal strength. I will finish with one important idea that is not much talked about, but I've used it myself, cilostazol. I haven't talked about pharmacotherapy. There's only one drug that has shown a reduction in instant tissue growth. It's cilostazol. Keep in mind that ticagrelor and prasugrel and clopidogrel reduce stent thrombosis. They do not reduce stent tissue growth. The only one to ever show that is cilostazol. Now, unfortunately, the data is old. There are 3 Korean randomized trials published in major journals that used cilostazol after de novo DES placement, not DES instant restenosis. But with that, they showed a dramatic reduction of instant restenosis of 50 to 65% among diabetic and long lesions. There are 3 trials published in good journal. Problem, they were de novo DES. They were only in one population, and most of them were old. The most recent one was 2018. There is one even older trial of cilostazol in the US after de novo bare metal stent placement. It also showed that cilostazol for 6 months reduced instant restenosis by 35%. Unfortunately, no trials in instant restenosis PCI and no recent modern trial. And I think it's reasonable to use it. Once you have DES restenosis and you're putting either another DES or you're putting a DCB, I think it's reasonable to using starting at that point. Certainly with your recurrent restenosis, so your third stenosis, it's very reasonable at this point. Your back is against the wall. It's very reasonable to use it. Keep in mind, it's a phosphodiesterase inhibitor, so it is contraindicated in heart failure with reduced EF, as it's a positive inotrope, so it's contraindicated in heart failure with reduced EF.